Giuseppe Neola and I am a medical oncology resident at the University of Naples Federico II. And I'm pleased to be here to present our study titled Relative Dose Intensity of Neoadjuvant Chemotherapy Predicts Pathological Response and Survival in Muscle-invasive urothelial cancer, a multicenter retrospective study. This project was conducted across in several academic centers across United Kingdom and Italy. I declare do not have any conflict of interest. So the aim of this study was to compare whether there is an association between relative dose intensity and pathological response in patients with muscle-invasive urothelial cancer. This work was built on a solid concept in oncology that preserving the relative dose intensity during systemic treatment, and particularly in the neoadjuvant setting, may significantly influence both pathological response and oncological survival outcomes. So, as you can see in this slide, the role of a relative dose intensity has been extensively explored in the current literature, and particularly in breast cancer, where it has been strongly associated with treatment efficacy and improved survival outcomes. But its role has also been examined in both localized and advanced stage of other malignancies, as an example for gastrointestinal cancers. But to date, no studies have never evaluated the impact of RDI in urothelial cancer, and specifically not in the neoadjuvant setting. Therefore, we designed and conducted this retrospective observational study, including patients with muscle-invasive urothelial carcinoma, stage CT2 to CT4, with or without nodal involvement, but M0. All patients were required to receive platinum-based neoadjuvant chemotherapy followed by radical cystectomy, and then, based on the relative dose intensity values, patients were retrospectively stratified into two groups. The group A, in the upper part, arm A, RDI over 80%, and group B, in the lower part, arm B, RDI lower than 80%. And a total of 306 patients were hence included in the study. So eligible patients met the following criteria. They were required to be older than aged 18 years old or older, to be affected from muscle-invasive urothelial cancer, to receive neoadjuvant chemotherapy followed by radical cystectomy, and to be affected, they were required to have a predominant urothelial histology for more than the half of their histological samples. But we selected only patients that received at least 3 cycles of platinum-based neoadjuvant chemotherapy. And this criteria was adopted because if we can see at the relative dose intensity definition, this is calculated as the ratio of the delivered dose over time to the standard planned dose over the standard time. So, in patients who received only 1 or 2 cycles, the denominator, so the expected treatment duration, would be disproportionately short, potentially leading to a falsely elevated RDI value. Indeed, we have to consider that, importantly, the dose intensity does not simply refer to the cumulative dose administered, but rather to the amount of drug delivered per unit of time. So this is a parameter that also incorporates treatment delays or dose reduction. By including only those who received at least 3 cycles, we answered that RDA values were based on a comparable treatment time frame. Our study primary endpoint was pathological complete response, whereas the secondary endpoints included event-free survival and overall survival. The median follow-up time was 32.7 months, and we were very surprised seeing that the pCR rate was significantly higher in patients in the RDI high group compared to those below that threshold. 47.8% versus 31.7%, with a p-value that met the statistical significance threshold. In multivariate analysis, which included also clinical parameters as clinical stage and nodal involvement, the RDI high remained an independent predictor of pCR with an odds ratio of 2.78. On the contrary, conversely, the event-free survival showed a favorable trend with a hazard ratio of 0.69, and similarly, overall survival favored the RDI high group with an hazard ratio of 0.61, despite not significantly statistically significant. This result point out to a potential survival benefit that, however, might become clearer with longer follow-up time and fewer censored observation. So, to conclude, we can see that maintaining a relative dose intensity over 80% during neoadjuvant chemotherapy is associated with a significantly higher pathological complete response in muscle-invasive urothelial cancer. But it also appears to be associated with better survival outcomes, although despite this requires further confirmation. In my opinion, future clinical trials in the neoadjuvant setting of muscle-invasive urothelial cancer should consider incorporating RDI as a stratification factor to be taken into account. And we can definitely say that this is the first study to evaluate the RDI role in urothelial cancer in the neoadjuvant setting, providing the current literature of a very important data. So thank you. I finished my presentation and I thank you all for your attention.